Rigid bronchoscopy is a widely used tool for the diagnosis and treatment of aerodigestive tract disorders. It provides excellent views of the pharynx, larynx, and tracheobronchial tree while providing the ability to ventilate the airway. This tutorial will provide an overview of the equipment, techniques, and required preparation and communication necessary for successful and safe bronchoscopy. In order to ensure that proper equipment and supplies are available, it is important to communicate with your nurses and scrub techs before the patient enters the room. The operative plan should be discussed with nursing and anesthesia personnel so that any questions regarding instruments and the upcoming procedure can be answered. Typically, a selection of several sizes of laryngoscopes, bronchoscopes, telescopes, and suctions should be present and well organized on the back table. It is critical to discuss airway management and the operative plan with the anesthesia team prior to taking the patient to the operating room. Elements such as bed positioning, critical airway findings, and ventilation methods such as jet ventilation or the potential for intubation should be planned before patient arrival. Appropriate endotracheal tubes should be readily available. In general, the formula shown here will provide for the appropriate uncuffed endotracheal tube size. However, if there are concerns for airway narrowing due to inflammation, disease, or foreign body, a smaller tube should be selected. In some cases, a cuffed tube might be ideal. The anesthetic team should be familiar with how to attach the circuit to the ventilating bronchoscope to prevent unnecessary delays or confusion. Shown here are the instruments of rigid bronchoscopy. From left to right, we have optical forceps with varying grasping elements. Next, a Parsons laryngoscope. Note the set of ventilating rigid bronchoscopes, which come in a wide array of sizes. We will go over the parts of the bronchoscopes shortly. The telescopes also offer varying widths and lengths, which need to be matched with the appropriate sized bronchoscope. Here we show a typical laryngoscope light handle with a straight Miller laryngoscope blade, as well as a curved Mac blade. A Miller blade is generally preferred during bronchoscopy. Attaching the blade to the light handle is simple, as the groove snaps into the top of the handle. Rotating the blade away from the body of the handle will activate the light source, like so. Next, we have a Parsons laryngoscope. Note the right slotted side channel, which allows for instrumentation. On the left side of the handle, there is a port for a light prism, which is introduced as so. Once a view of the larynx is obtained, lidocaine may be applied topically to the larynx to prevent laryngospasm and decrease airway reactivity. A typical applicator is shown here. This chart outlines rigid bronchoscope sizes. Note that some sizes come in multiple lengths to accommodate neonates, infants, and older children. Always have one size down instruments available in the event of resistance to bronchoscope advancement. The 2.5 rigid bronchoscope is the smallest available and can be used to secure an infant's airway in case of subglottic narrowing or obstruction. A ventilating bronchoscope can be identified by the presence of open ventilating ports near the distal end of the shaft. Also note the tapered end, which allows for atraumatic insertion. There are multiple ports on a Storrs bronchoscope. First, we have the ventilation circuit connector, followed by the light source port. Next, there is the main instrumentation and telescope channel. Lastly, there is the suction port. Now we will cover the components involved in proper assembly of the bronchoscope. First, we have the suction port adapter and a rubber stopper to prevent the escape of ventilated gases when not in use. It attaches like so. Next, line the inner notch up with the respective section on the suction port and snap it into place. It should fit securely onto the bronchoscope if placed properly. This port can be used to pass flexible bronchoscopic suctions ranging in size from 5, 7, and 10 French. Also, this is the port where a laser fiber may pass. Next is the main channel through which the telescope is placed. First, a locking adapter is used to bridge the bronchoscope and telescope together. There is a lock and groove for appropriate bridge placement. Next, the telescope is inserted through the bridge with a light cord adapter facing in the same direction as the light source port. The bridge also prevents the telescope from extending beyond the distal end of the bronchoscope. The bridge is turned clockwise from 9 o'clock or unlocked position to the 12 o'clock or locked position. Next, a prism is placed to allow proximal lighting. This can be placed 1 or 2 clicks deep. Without the prism attached, proper ventilation cannot be performed. It should be noted that if positioned more than 1 click deep, the prism will partially occlude the main channel of the bronchoscope, making it difficult to pass telescopes and instruments. A mouth guard should be placed to protect the patient's teeth. Alternatively, a wet gauze can be placed to prevent harm to the gums on edentulous patients. This is the full bronchoscopy setup. Note how multiple bronchoscopes have been assembled, along with a pair of optical forceps. It is important to confirm that light sources are functioning. The endoscopes and bronchoscopes are properly set up, the optics are adequate, and the suction equipment is functional. If possible, this should be done before the patient is sedated. Patient positioning is critical to safe endoscopy. The neck is extended and head raised in the sniffing position with the aid of a shoulder roll. The table may be rotated 90 degrees away from the anesthesiologist. In children less than 6 months, you may consider not using a shoulder roll as it can position the larynx too superior and anterior. Here we show the recommended hand position during direct laryngoscopy. Note the thumb at the base of the laryngoscope and the index and middle fingers supporting the laryngoscope. The ring finger is on the mandible to allow for jaw adjustment, and the pinky can apply cricoid pressure or mobilize the larynx to assist with visualization. Displayed here is mask ventilation. The thumb and index fingers are used to apply gentle pressure to the mask over the nose and mouth. The middle, ring, and pinky fingers are placed along the mandible. Care should be taken not to press on the soft tissues in the submandibular region, as that can inhibit adequate ventilation. During this time, the bronchoscopist should communicate with the anesthesiology team and the scrub tech to ensure that everyone is ready for the procedure to begin. The correct instruments are available, and the ensuing series of events are clear to everyone involved. When the team is ready, remove the mask. Then place the mouth guard, or wet gauze if there are no teeth present, over the gums. Next, scissor the mouth open with your right thumb and index finger on the mandibular teeth and maxillary teeth, respectively. Slowly introduce the laryngoscope into the oral cavity, making sure to enter on the patient's right so that you can sweep the tongue toward the left. At this point, it may be necessary to suction away oral secretions to obtain a clear view. After the direct laryngoscopy has been performed, the ventilating bronchoscope can be introduced into the mouth and passed towards the larynx. First, obtain a global view, then advance the scope so that the leading tip passes through the cords atraumatically. Given the taper of the bronchoscope's leading edge, it may be advantageous to rotate the bronchoscope left or right by 90 degrees, so that the bevel more easily passes through the cords. Next, gently move the scope to center the view in the tracheal lumen, and notify the anesthesiologist to attach the ventilation circuit and confirm adequate ventilation. With the scope in the subglottis and adequate ventilation, you may remove the laryngoscope and reposition your hand onto the shaft of the bronchoscope. Advance the scope using your left thumb to keep it off the maxilla and mouth guard. Care should be taken to keep the view centered at all times with the bronchoscope straight. If the scope starts to bend, you will begin to see a dark crescent form on the video feed, indicating that you are affecting the optics. Suction is needed to view the subglottic region, assessing lumen diameter and identify any masses or lesions. Then advance the scope. As you advance the bronchoscope, take note of the posterior wall and shape of the tracheal rings. As you reach the distal trachea, examine the carina and prepare to evaluate the main stem bronchi. To explore the right bronchus, turn the head left to align the scope with the bronchial lumen. Advance the scope and examine the bronchial tree. Then withdraw the scope until you have a view of the carina again. Rotate the head back to midline and then to the right to perform a left bronchial examination. If needed, the laryngoscope can be suspended into position to maintain a view of the larynx. Once the desired view of the larynx is obtained, hold the laryngoscope firmly in position as the scrub tech positions the Mayo stand and suspension arm. Make sure an angled gray light cord is connected to the laryngoscope and that the suspension arm attachment is the appropriate size. With the suspension arm secured to the handle of the laryngoscope, lower the suspension arm using the knob onto the Mayo stand. This stabilizes the laryngoscope so that you will have 2 hands free for performing the rest of the procedure.